Hello everyone. Now today we are again continue our previous lecture of nephritic syndrome. It is not finished yet, although we can discuss the remaining cause, that is membranoproliferative glomerulonephritis, which is known as the MPGN, or diffuse proliferative glomerulonephritis, also known as DPGN, can be discussed with nephritic syndrome as well. But since it is mentioned in your first aid, so we are going to complete here itself, and there will be a revision in your nephritic syndrome when we will talk about it. Okay, so we are talking about the nephritic syndrome. The nephritic syndrome, which was common in your children due to acute post-cystal glomerulonephritis. Then we talked about the rapidly progressive glomerulonephritis. Then we talked about the IgA nephropathy that was related to your mucosal infection, and then we talk about the Alport syndrome, where it was there is a family history with the problem of eye, ear, and kidney. So we have talked about it, and we have talked about the detail of each and every causes. Okay, so always you have to understood that nephrotic syndrome or nephritic syndrome, which we are talking, since here we were talking about the nephritic. So nephritic is we have already told you that the hallmark is inflammation of the glomerulus, and there will be the bleeding, that we have talked about it. So in nephritic syndrome we have also talked about that there is three features like oliguria, azotemia, and hypertension. Okay, and when we talked about oliguria, azotemia, and hypertension, then these are the characteristic finding. Okay, and we may discuss at the end of our lecture today also. Okay, now the remaining cause that is responsible for nephritic syndrome are membranoproliferative glomerulonephritis and diffuse proliferative glomerulonephritis. Okay, since we are talking about membranoproliferative glomerulonephritis, MPGN can co-present with nephrotic syndrome. So it means both nephritic and nephrotic syndrome can be present at a time. Okay, there are two types in case of membranoproliferative glomerulonephritis, that is the type 1 and type 2. Okay, when we talk about the type 1, it is related to hepatitis B or hepatitis C infection. So secondary to hepatitis B and hepatitis C infection, or maybe idiopathic. All nephrotic or nephritic syndrome can be due to idiopathic. Okay, but there are some association, like type 1 is typically maybe secondary to hepatitis B and hepatitis C infection. And if in your scenario, and this is very high, if in your scenario they are talking about the hepatitis B and C infection, then he develop kidney problem. They are saying that there will be hypertension, oliguria, azotemia. They are giving a picture of a nephritic syndrome. Then you have to understand, okay, they are talking about membranoproliferative glomerulonephritis, and that in particularly to type 1. So this is important. Okay, so now the next is that type 1 is subendothelial immune complex deposit. That you have to understand. When we have talked about it, then we have talked that there is the endothelium, then is glomerular basement membrane, and there is also the epithelium. Okay, when comes about the immune complex deposition, the immune complex deposition will be occurred in the subendothelium. So this is endothelium. So just below the endothelium, this is glomerular membrane, above the glomerular basement membrane. Okay, so epithelium, glomerular basement membrane, and endothelium. So subendothelium, there will be immune complex deposition. Okay, now and on immunofluorescence, when you examine the slide, when you examine the material on the immunofluorescence, there will be the granular appearance. You know, when you talked about the immunofluorescence, there will be the linear, that is the clear cut. When it comes about the dotted appearance of the immunofluorescence, then it was due to granular immunofluorescence. Okay, so this will be granular immunofluorescence. Okay, and when we see on the PAS and HE stain, that is stain, then what we'll find the tram track appearance. What is that tram track appearance? Look, the name indicates a lot of things. It is membranoproliferative glomerulonephritis, means that there is a damage in the membrane. Although nephritic syndrome or membrane damage, glomerular basement membrane damage. So this is a damage on the membrane where there is a proliferative disease. Okay, leads to glomerulonephritis. So membrane damage, we have talked about. This is the membrane damage. Okay. Now, since they are talking about the proliferative name, so proliferative helps to remember us about that there is a tram track appearance on the PAS and HE stain due to this glomerular basement membrane. You see, here is your glomerular basement membrane. Okay, and there is immune complex deposition. This is endothelium. This is glomerular basement membrane. This is epithelium. There is the mesangium. Mesangium is the connective tissue that would lot of glomeruli. Okay, now what happened? This glomeruli, this mesangial will proliferate and will bisect when will split the immune complex. Okay, and this immune complex splitting will occur by the mesangial. Okay, and this splitting occurs by mesangial leads in the formation of this railway-like track, tram track, and so it is known as the tram track appearance, which we will see on the pass and H stem. That you have to remember. Okay, so what? Look, this we are talking about subendothelial immune complex deposition. That is also okay. We are talking about the granular immunofluorescence. Granular immunofluorescence will be in a lot of conditions. We have talked about that linear is in Goodpasture syndrome and granular will occur in the acute post-streptococcal glomerulonephritis. Then we have talked about diffuse proliferative glomerulonephritis, membranoproliferative glomerulonephritis. Even when you come about the nephrotic syndrome, there is a membranous nephropathy. These all are has immunofluorescence, that is granular. Okay, then in particular, how we can differentiate? We can differentiate with the help of other features. Okay, if immunofluorescence are same, so we can use, suppose in acute post-streptococcal glomerulonephritis, there was subepithelial hump. There was here hump. Okay, so here was the hump. So that was differences from your subendothelial or intramembranous. Okay, so membranoproliferative well different from your subepithelium. It has subendothelial or intramembranous deposit. Okay, type 1 has subendothelial deposition, type 2 has intramembranous membranous deposition. Okay, so I think you have understood this tram track appearance as well. And the tram track appearance, if they are mentioning it, then it is clear they are talking about the membranoproliferative glomerulonephritis. Okay, now when we talk about type 2 is intramembranous immune complex deposition. Where here we have talked about that subendothelium, but here it will be on the membrane, intramembranous immune complex deposition. Okay, and so it is also called dense deposit disease. And the characteristic feature of type 2 is that it is associated with C3 nephritic factor. When you understand the complement has a pathway that begins. Okay, and there comes a one step where there is the C3 convertase. C3 convertase, what do it proceed the complement pathway. When complement pathway is activated, C3 convertase activate and proceed that cycle, and it get usually degraded. But if anyhow that enzyme get stabilized, not degraded, then complement pathway will be continuously stimulated and continuously circulate. So there will be a continuous complement activation in your body, and because of that there will be other damage due to the complement in product and byproducts. Also there will be decrease of C3 level due to the consumption of complement protein. So you have to understood, if C3 is decreased also, although we have found that there is C3 complement decrease in most of the nephritic syndrome, but when we are talking about the type 2, then it is especially related to C3 convertase, and there will be C3 inhibition, decrease in C3 level. Okay, so this is all about your membranoproliferative glomerulonephritis. Now comes to the diffuse proliferative glomerulonephritis. Diffuse proliferative glomerulonephritis can be occurred due to membranoproliferative glomerulonephritis or due to SLE. Okay, and the common cause of death in SLE is due to diffuse proliferative glomerulonephritis. Okay, and we know that this both MPGN and DPGN both can present concurrently with nephrotic and nephritic syndrome. That is already known. What we need to understand more about diffuse proliferative glomerulonephritis are, on light microscope, there will be wire looping of the capillaries. When you see the light microscope, there will be wire looping of the capillaries. Immunofluorescence will be granular, we have discussed about it. And on electron microscopy, there will be subendothelial or sometimes intramembranous immune complex deposition. So it will be same as this, only the difference is that here will be light microscopic finding will be a wire loop of capillaries, whereas here light microscopic finding, which is in the pars and H stent, the tram track appearance. That will helps to differentiate you between the membranous proliferative glomerulonephritis and diffuse proliferative glomerulonephritis. Okay, so there was granular appearance was post PSGN. Okay, linear was your Goodpasture syndrome, but we are not talking about it. We are talking about, there is a confusion between immunofluorescence only. So PSGN has granular, but there were all subepithelial hump, so we are diagnosed it. Now this is subendothelial and intramembranous. This is also subendothelial and intramembranous. granular immunofluorescence. Okay, both same, but on light microscope there will be loop wiring of the capillaries in diffuse proliferative glomerulonephritis, whereas there will be tram track appearance into the membrane of proliferative glomerulonephritis, and in this way we can differentiate between these two. Okay, now the important thing is that you need to understand the most common cause will be SLE. Let's discuss some high yield point regarding the SLE. SLE is systemic lupus erythematosus. The most common cause of death in SLE patient is due to renal failure. Okay, so if a SLE patient dies, then you have to understand it is the most common, it has died due to renal failure. Okay, and if renal failure occurs, renal failure can occur by two methods. One is nephritic syndrome and one is nephrotic syndrome. Okay, the most commonly occurs by nephritic syndrome, and since if nephritic syndrome occurs in a SLE patient, then that will be due to this DPGN, that is diffuse proliferative glomerulonephritis, that you have to understand, and which is high yield. If they are talking about SLE patient and saying nephritic syndrome, you directly jump to the diffuse proliferative glomerulonephritis. They are talking about diffuse proliferative glomerulonephritis. You have to understand that. Okay, and this is being good to understand and to grab the questions. Okay, so SLE patient die, it will be the most common causes renal failure. If SLE patient develop nephritic syndrome, then it will be due to a diffuse proliferative glomerulonephritis. Okay, and if patient develop nephrotic syndrome, okay, then we'll talk about it, then which is due to the membranous nephropathy. That is another cause of causing nephrotic. We have not discussed the nephrotic syndrome. Okay, so this can also cause nephrotic syndrome. This can also cause nephrotic syndrome. There are other like minimal change disease, amyloidosis, diabetic nephropathy. Okay, there is focal segmental glomerulosclerosis, and these two, and one is membranous nephropathy. So if nephrotic syndrome develop in the SLE patient, then it is due to membranous nephropathy. If nephritic syndrome develop in the SLE patient, then it is due to DPGN. And the most common cause of death in SLE patient is renal failure. This is high yield. Okay, and there may be a question related to this, so you have to have master in it. Okay, so we have almost completed our nephritic syndrome. Let me overview again in short. Since we are talking about the nephritic syndrome has what are the components? See, there is a glomerular inflammation. So since there is a glomerular inflammation, the glomeruli is so inflamed that blood supply, actually inflammation, blood supply increases. But here in nephritic syndrome, due to glomerular inflammation, the blood supply decreases. Since there is a decreased blood supply, there will be oliguria. Because there is decreased blood supply, decreased GFR, decreased urine formation, oliguria. Since decreased urine is formation, the nitrogenous waste product from your body will not be taken out. So there will be development or increase in nitrogenous waste product in the body, and it will lead to develop of azotemia. Okay, and since there is a oliguria, GFR is decreased. Now the renin angiotensin aldosterone mechanism will be activated. There is less sodium content to the distal convoluted tubule, and there is this renin angiotensin aldosterone mechanism has increased, which has, if you remember, it will lead to the angiotensin 2, and angiotensin 2 is responsible for vasoconstriction, and vasoconstriction will cause hypertension. So there will be bleeding, damage, so hematuria, and this oliguria, azotemia, and hypertension. So these are the findings of your nephritic syndrome, and it will be easy to remember for you. Thank you.